Welcome to The Explainer. So today we're tackling a topic that puts you right on the absolute front line of medical care. Whether you're planning to be a general practitioner, an ER doc, or a surgeon, you are going to be the very first line of defense for patients with musculoskeletal injuries. We're covering the absolute basics of orthopedic triage today, and honestly, the stakes here are incredibly high. A missed sign or a delayed referral can literally mean the difference between a patient making a full recovery and a patient losing a limb. So grab your notebooks because we're building your foundation today. Okay, let's dive right in. Here's our roadmap for building your triage toolkit today. We'll look at why orthopedics matters, unpack the musculoskeletal toolkit, master some essential terminology, learn how to spot the red flags, and finally, figure out exactly when to refer urgently.
All right, part one, why orthopedics matters.
I really want to emphasize right off the bat that this isn't just a subject for future orthopedic surgeons. This is a daily, unavoidable reality on the medical frontline. So why does it matter for every single doctor? Well, it's pretty simple. Practically every patient you see in your career is going to, at some point, show up with joint pain, a fracture, or some kind of sports injury. And they aren't going straight to the surgeon, they're coming to you first.
By definition, orthopedics is the branch of medicine dealing with the musculoskeletal system, sure, but the ultimate goal here, it's to restore function, reduce pain, and improve their quality of life. Even if you never, ever set foot in an OR, you absolutely need this foundational knowledge. Your initial assessment dictates the urgency of their condition and kicks off their safe management. Basically, you're the gatekeeper to their recovery.
You're going to hear these exact phrases all the time. My knee hurts after running. I took a fall and my wrist is super swollen. My shoulder pops every time I lift. Now, these aren't just everyday complaints you can brush off. To a trained ear, these often represent hidden fractures, severe ligament injuries, or meniscal tears. Grasping these patterns, that's how you triage effectively.
Moving right along to section 2, the musculoskeletal toolkit.
Now, what's really interesting about this is, to fix the machine, we first have to understand the biological hardware we're actually dealing with, right? And the body's mechanical engineering is honestly elegantly simple when you break it down. You've got your bones acting as the rigid structure and protection, whether they're long, short, or flat. You have joints, which are the pivots allowing movement, like the hinge in your knee or the ball and socket in your shoulder. And then, of course, you've got the muscles, the body's engine, generating the force needed to actually control all that movement.
Okay, here's where people constantly get tripped up, even late into medical training. Ligaments connect bone to bone. Their main job, providing stability. Think of them as the seatbelts for your joints. Tendons, on the other hand, connect muscle to bone. Their job is transmitting force to actually allow movement. They're the pulley cables. Try to keep that functional difference, stability versus movement, totally locked in your mind.
All right, section 3, essential orthopedic terminology.
This is the vocabulary you absolutely have to master to communicate effectively on the floor. Let's rapid fire through these core terms because recognizing these is literally step 1. A fracture? Simply a break in the bone. Deformity means an abnormal shape or alignment. You look at the limb and it just doesn't look right. Instability is when the patient tells you their joint feels loose or maybe it literally gives way under them. And a limp is just an abnormal walking pattern, usually secondary to pain or some underlying weakness.
And this brilliantly illustrates two terms that are frequently confused, but where precision is totally vital for your diagnosis: dislocation and subluxation. A dislocation means the bones in a joint are entirely out of their normal anatomical position, completely separated. A subluxation, though, that's a partial dislocation. The bones have shifted out of place, but they're actually still maintaining some partial contact.
Which brings us to section 4, spotting the red flags.
I'm going to drop the energy just a bit here because we are entering the absolute high-stakes danger zone of this explainer. We need to talk about red flags. These are the monsters in our clinical story. These are signs that suggest serious, potentially limb-threatening or even life-threatening problems. As a frontline doctor, you absolutely cannot afford to miss these. No way.
Spotting these requires immediate clinical suspicion. You need to watch for severe pain that completely ignores rest, or a patient who is entirely unable to bear weight. Be on high alert for open fractures. That's where the bone actually communicates with the outside air. Look out for fevers paired with hot, swollen joints, which screams infection, or really any deformity that's rapidly worsening right before your eyes.
And within those red flags, we have to highlight a very specific, very urgent category: neurological deficits. If your patient has unexplained weakness, numbness, or total loss of movement distal to the injury, well, that means a nerve is actively being compromised. The clock is ticking incredibly loudly here.
Let's move to section 5, when to refer urgently.
Now that you can spot the danger, let's give you a clear, actionable framework for exactly what to do next. Because triage is ultimately a game of timing. Knowing the difference between an immediate referral and an urgent referral can quite literally save a patient's limb. Immediate means you act right now. Drop everything, get the specialist on the phone. Urgent means they need to be seen today or at the latest the very next day.
So here are the scenarios that demand that immediate referral. Open fractures, for sure, because the infection risk is just massive. Dislocations causing neurovascular compromise, meaning blood flow or nerves are actively pinched. Severe limb deformities, and crucially, signs of compartment syndrome. This is a terrifying condition where swelling builds up inside the muscle compartment. You want to look for extreme pain, especially pain when you passively stretch the muscle, and swelling that feels incredibly tight. Time is directly tied to tissue survival with this one.
On the other hand, we have our urgent referrals. These are slightly less critical than immediate, but hey, they still require rapid expert intervention within 24 hours. We're talking about suspected fractures that have significant deformity, any suspected joint infection, or severe soft tissue injuries that have some sort of neurological involvement. So the crucial point is this. As the doctor on the front line, your main job is not to perform the surgery yourself. Your role is a three-step process. Number 1, recognize those red flags we just talked about. Number 2, start safe initial care, which means stabilization, immobilization, and getting that pain under control. And number 3, refer appropriately and early. You've got the knowledge now to safely manage that front line.
But this brings us to a bit of a clinical cliffhanger. Now that you know exactly how to spot the critical red flags on paper, how are you actually going to structure your patient history and your physical exam to uncover them in a real chaotic clinical setting before it's too late? Think about that, because that is exactly what we're going to conquer in Module 2. Keep learning, stay curious, and I'll catch you in the next explainer.